Hello there. Happy Friday to you. My name is Julie Hirschberg. I am the owner of Reactive Physical Therapy and Wellness here in the LA area. And this is a specialty practice for neurology, for PT, for OT, for exercise. We're adding psychology actually to our group in the new year. And it's also home of the Schmidt Movement Disorders Fellowship, which is a specialty program for physical therapists to learn more about movement disorders. And this is exactly one of the reasons that we are diving into a particular movement disorder today, that is tremors and myoclonus, because this is falls under the movement disorder umbrella, and it's commonly misunderstood. One of the things that we do as part of our fellowship program is we do a lot of training and learning together. And we've been doing this for a long time. One of our very first courses was really on tremor. And we started sharing these courses with the world, recording them and doing them live online. And our very first course to kick off 2021 is going to be on differential diagnosis. And a lot of that in understanding these different types of movements that come up in movement disorders. So, this is a little sneak peek of the course for you because last week I put out a question to our community about what topics people are most interested in. And movement disorders was a big topic. And two particular questions really caught me. And one was, what are the causes of myoclonus? And one was experiencing tremors or jerks after concussion. And I was just like, oh, yes, I love to talk about this. I love to learn about it as well. So I've been learning all week, reading all kinds of literature and just looking at updating the course that we're doing next month. Actually, we're doing it in January. And so I'm going to share that with you today. I'm really excited about it. So thanks for those great questions. Thanks for sending those my way. And what we'll talk about today is a framework for differential diagnosis and movement disorders. And then we'll kind of zoom in because myoclonus is just one piece of movement disorder and tremor is just one piece. And because somebody asked about concussion, so we're going to definitely talk about that. By the way, I just want to give a preview coming up in December. If you know Molly Parker, if you don't, you should. She's an amazing PT who has had a personal experience with concussion and just puts out a lot of great information and works with Natasha Welch to do Concussion Compass. I am hopping on with her live at the end of this month to talk movement disorders after concussion, by the way. So you'll have to grab that as well. And I will be doing something in Concussion Compass for movement disorders. So this is my love. You can't tell. So, one thing that I do have to say that this is not medical advice. So, this is my disclaimer. One of the things that I say a lot is if you are experiencing movement disorders, you should see a movement disorder specialist, a neurologist who's been specially trained in this. And particularly if you're having tremor or myoclonus, I work very closely with a lot of movement disorder specialists, and I think when it comes to getting the correct diagnosis, working with somebody who has that specialty is so important. So, a lot of what we're going to talk about today actually comes from the literature for neurologists and movement disorder specialists and how they go about this diagnostic process. Because as therapists, we're not diagnosticians, we're not giving people diagnoses, but when we see people, we do need to screen and understand what is happening. So we're going to start with this framework. And so there's a really wonderful article, by the way, and I'll put a link here because you can get it free, full text, which really talks about this clinical approach to movement disorders and provides a really systematic approach for diagnosis. And so they basically walk through this process of looking to somebody have one or more movement disorders, because often there's more than one. Identifying the subtype, and we're going to talk about this a little bit. Is it hyperkinetic, too much movement, hypokinetic, not enough? Um, Identify associated neurologic features that go through that. So, really good neuro exam. And then identify non-neurologic features, because there may be other things happening, right? And putting those pieces together into a clinically based syndrome. Many of the movement disorders are diagnosed clinically. And maybe you've experienced this. There's not a blood test, there's not an MRI, a CT scan that can really be definitive. It's a clinical diagnosis, but it's a positive clinical diagnosis. And then a diagnostic workup. So going through some of those things, and we have better technology now for some of these things, and I'm going to talk about that a little bit. For example, I'm not going to talk about this, but a good example of this is in Parkinson's. Now, a DAT scan can be used to help clarify something that might not be clear clinically. And I'm going to talk about a little bit about the neurophysiologic testing that can be done in tremor and myoclonus. It's primarily done in research right now, but I think we're finding this more and more, that these things are going to be coming to just state of the practice, right? So I'm excited about that. So that's this process. We start putting together things into a syndrome. And when we look at this, kind of break it down a little further, as I mentioned, we look to see in that movement disorder, is it too much movement, which is the hyperkinesia? That's what we're going to talk about today, tremor and myoclonus. Or is it too little movement? And I think a lot of people are pretty familiar with that, things like bradykinesia, hypokinesia, things that you might see in a disorder like Parkinson's. But if it's too much movement, you can actually further break this down a little bit more and characterize it as jerky or non-jerky movements. And today we're going to talk about one of each. So in that jerky category, myoclonus fits, and in the non-jerky, tremor fits. So we're going to talk about one of each, so you get a little sample of this process. So are you ready to dive in? Let's talk about myoclonus. So myoclonus fits into that hyperkinetic, too much movement, involuntary movement, and in the jerky category. So it's not rhythmic. And it's typically this very sudden, brief, shock-like movement in the body. Now, here's something kind of cool. I don't know if you knew this, but we have probably all had some form of a myoclonus. So a hiccup would be a good example of a myoclonic jerk. Those little jerk things that you get when you're falling asleep, maybe you don't realize them yourself. Sometimes they wake you up. Maybe you notice them in your spouse or your kids. That's called a hypnic jerk. That's myoclonus. Normal. It's physiologic. So there you go. You've all had myoclonus at some point. But what we see clinically is not somebody that's concerned about that. They're concerned about something else causing the myoclonus. And there's a lot of different causes. So I'm going to hit on a few of the most common, but I'm going to start because 30 to 50% of people presenting with myoclonus it's functional myoclonus. So it's pretty high percentage. So I'm going to start there, and then we're going to talk about the others and how you might differentiate them. So what is functional myoclonus? Functional myoclonus often occurs after an injury. So you might see it as part of CRPS, or complex regional pain syndrome. You might see it after a concussion. You might see it occur and stay prolonged after a side effect of a medication, or a fainting episode where you get some physiologic myoclonus with that, after an infection, maybe after hospitalization. So those can all be things that can be the start of the myoclonus. And sometimes there is actually another cause of the myoclonus that can become amplified with functional myoclonus. And this is something that I think I'm seeing more and more is these layers, and you have to kind of peel away the layers of the myoclonus. What does it look like? So, the a functional myoclonus will often look like a jerk of the body. So sudden movement of the body can also be found in the limbs. It will often occur out of the blue, so very sudden onset. It can involve the face and maybe even the voice. What you might see when you're walking is a like sudden jerk downward. That's a common pattern of it. Um, and one of the things with the functional disorders, because we know it's a connection issue, is that it can change. It might be a little variable, it might be distractible. It doesn't mean at all that it is not real at all. It is not made up by any means. It's a very real form of myoclonus. It just has a different pathophysiologic feature in that it can be variable. For some people, it can there can be a like sense that of tension and the jerk relieves it. That's not, I've only seen that in a couple of people. Um, and one of the things that is really interesting coming out in literature with this type of myoclonus is that in research studies, they're finding some electrophysiologic features of it. So they will find, for example, there's very specific features of the different types of myoclonus. And in a functional myoclonus, they'll see variability in the muscle recruitment and variability in the burst duration of the myoclonus. So there are also a few other things. I won't get into the details because they're really quite complicated, but there are some signs that are very specific on an EEG. So mostly this like video, polymyography, the EMG, EEG, those are mostly done in the research setting. But again, this is starting to grow so that we can start to see this diagnostically. So many of the different types of myoclonus have a neurophysiologic feature, and as does functional myoclonus, which really shows us that it's indeed a physiologic process that occurs, and it occurs differently. So myoclonus from the spinal cord versus myoclonus from the cortex, those have different neurophysiologic signatures as well. So, so I wanted to start with that because with the functional myoclonus because it's so common and it can be triggered by a concussion. As we know, in a concussion, there's a host of metabolic and physiologic events that can occur in the brain and the brainstem, like we even the spinal cord, and that can be a condition that sets up for myoclonus. So, so that's the first one. I want to talk. There's many, many kinds, by the way, more than I ever imagined. I actually downloaded and read a whole book on myoclonus because it was so fascinating, and I love to read, and I just couldn't believe how many different types there are. So if we just go kind of broadly, I talked about physiologic, which is a normal piece of myoclonus. You can actually get that also with exercise induced. You can have it with a heightened nervous system as well. And then those things would be variable. And that then might show up as a functional myoclonus. And normal and can be retrained, which is the really good thing. We're not talking about treatment today, but that's really important. Now, what is also important is that there are other things that can cause myoclonus. So epilepsy, Some of the neurodegenerative diseases like multiple systems atrophy, Huntington's disease, cortical basal degeneration, some of the viruses that affect the brain as well. So something like the AIDS virus affecting the brain. Um, so those things are typically seen in imaging and neurodiagnostic studies and lab tests so that we can rule those out. So I didn't want to leave anybody feeling like their myoclonus was the start of a neurodegenerative disease by any means. They have a whole host of other neurologic symptoms with that. Metabolic disorders can also cause myoclonus, so liver failure and kidney failure. And again, that would be a part of a broader picture of things. But if somebody has a change in symptoms, these are things, and they're not being seen by their doctor. These are the things that as a therapist we'd be referring them out for. Um, and there's some similarities and overlap with tremor here because toxins, heavy metals, for example, certain drugs can cause myoclonus, even heat stroke. So we get some of those electrolyte imbalances. All of those things can cause myoclonus and would be important to rule in and rule out. Um, so the list could go on and on. You could have a whole book on this, but I wanted you to get a glimpse of kind of the broad picture. One of the most common is functional and physiologic myoclonus. And then we can look at things that are related to other disease or metabolic or toxic processes. So in a nutshell, there's myoclonus. Um, by the way, I welcome questions. Again, I'm not a neurologist. I'm a physical therapist, and I'm a physical therapist in the neurology world. Yes, and my purpose in really understanding this is that I can help screen somebody and get them connected for the right diagnosis. Right. So. So we talked, this was our framework, right? Hyper or hypokinetic, we're in the hyperkinetic. We did jerky, myoclonus. We're going to talk about one of the non-jerky movement disorders, which is tremor. We see this so much. Now, tremor is identified by its rhythmicity. It's rhythmic, alternating movements of one or more body parts. We see it in the arms, we see it in the legs, we see it in the head, the chin, the lips. You can see tremor anywhere. It's involuntary. Um, and actually, I saw tremor in the palate yesterday. So tremor then can be further broken down into the types. So it could be a resting tremor, you see it at rest, or you can see it with action, or in a combination. And just like in myoclonus, I want to hit on functional tremor first because it's so common, and it also because it can fall into both categories of resting tremor and um, and action tremor. So much like myoclonus, functional tremor can begin kind of out of nowhere. It can be sudden, but it can also come on really gradually. Similarly, it can be that initial onset could be with a physical injury or a side effect of a medication. I'm going to talk about both of these with concussions, and somebody asked me that very specifically, but absolutely concussion could be the onset of it. Um, the Sometimes what we can see is actually a Parkinsonian type tremor or essential tremor with functional tremor as well. And again, we have to peel away those later. I already got a question. Thanks, Nicole. Do you ever see a delay of months from concussion to myoclonus? Great question. And yes. And this occurs with mild brain injury like concussion and severe brain injury. We can see a delay of some of these movement disorders. And now I know the answer to this, Nicole, because I can remember the first time I saw somebody, it was actually after a stroke. So you can have a delay in movement disorders after a stroke too. And I had been seeing them, and they said, well, I got this myoclonus, and it was, a year later. And I was like, that seems weird. It's something going on. And I talked to their neurologist, and they said, oh, yes. And then I went to the literature, and yes, indeed, it can be delayed. Fascinating, isn't it? It's really fascinating. So, mild brain injury, severe brain injury, you can have delayed onset of myoclonus or tremor. And we see this a lot in concussion, in the post-concussion symptoms, that we can see some changes in some of the movement disorders developing later on. And that may be part of, there's a lot of conjecture here of people trying to understand why this is happening, part of the brain process of recovering, even. Um, Okay, great question. So going back to the functional tremor, again, as I said in the beginning, I think this is best diagnosis made by neurologists and movement disorder specialists, um, and somebody that really sees a lot of tremor because um, they can be so similar. So some of the things that look more distinct functionally is that it might change the rhythm. So the frequency of the tremor might change. It might change with pressure or weight. This is something that I see a lot. So there's some variability or inconsistencies in it, similar to what you see neurophysiologically in the myoclonus, by the way. That it might be distractible, or it might change in the environment, and that's important too. But really, a lot of the tremors can have these qualities because a lot of tremor increases, for example, in a very stressful situation. And so, whether you have Parkinson's, whether you have essential tremor, whether you have physiologic tremor, whether you have functional, it doesn't matter. They're all going to increase. Um, Often when the nervous system is in a really excited state because it's a hyperkinetic movement disorder. So there's this extra excitability, less inhibition. So, um, that some of the things that we might look at then to know if it's functional is to see if there's times when the tremor's not there. We'll look at that variable frequency. We'll look to see if there's some difficulty making rhythmic movements with the hand, and we look for something called a entrainability. Does the tremor train to the rhythm of another body part or music or things like that? Those are, again, positive diagnostic signs that there is a connection problem causing that tremor. So, so that's the functional tremor. Let's talk about a couple of others. So, I mentioned we kind of break it down into rest tremors and action tremors. So, rest tremor is best looked at when we're seeing something fully rest and having that body part fully supported, so that they're not having to work against gravity. The best example of a resting tremor is in Parkinson's disease. That's probably what people have seen most common. And under action tremor, there are several types. So we can see a postural tremor, a kinetic tremor, and then some kind of miscellaneous tremors. But let me give you a couple of examples of of the common ones. So essential tremor is the most common of tremor disorders. It's also one of the most common neuro disorders, by the way, in adults, and it actually can be genetic. It can be sporadic too, and it can respond to medication, which is great. By the way, I just realized I'm hanging out in here with not a commercial by any means, but this is the room that our OT is typically in. There are things that can help tremors, especially essential tremors, and the lift wear is one of those things, by the way. Love having options for people. And Jennifer is asking questions. Great. We're going to have a whole nother session here on treatment because there is so many exciting things to do. I'll give a couple of things today, Jennifer, but let me finish talking rest action. Essential tremor is one of those. A cerebellar tremor would be that kinetic tremor. So that's that. It's really a dysmetria, but you see it in action. So you see an over and undershooting with a cerebellar type of tremor. So when we think about underlying causes for those, again, they can be neurodegenerative, it can be brainstem induced, it could be stress induced or exercise induced, much like myoclonus, endocrine disorders, different drug interactions, stroke, MS. Those could all be sources of tremor. But what we would then see is a host of other neurologic symptoms that would support those diagnoses, as well as imaging and blood work. So, again, the most common forms of tremor are benign. They're essential tremor, physiologic tremor, and functional tremor. So most people do not have, luckily, one of these, an endocrine disorder causing their tremor, metabolic disorder, a toxic disorder causing a tremor. But that's why you see a movement disorder specialist, right? So that you can have all of those special tests to ensure of what your tremor is. And because Jennifer asked me, so let me just summarize that. We'll just talk a little bit about treatment. So what we talked about is this framework of kind of differential for these. Hyperkinetic is what we focused on today. Hypokinetic, we'll have to do that another day. And then we further went into myoclonus. We talked about some of the causes, and tremor, some of the causes. Because when it gets to treatment, it will often depend on the cause. So that's really important. So some of the things that that we talk about are not applicable in all places. So, for example, I saw somebody yesterday who has tremor due to a stroke in the brainstem, and so multiple causes of that in the pons, in the cerebellum, that could be causing tremor, and we're going to treat that very differently because it's associated with ataxia and some sensory loss. So that's very different. Essential tremor tends to respond really well to some of the like liftwear devices that I showed you. And there's some emerging literature, and this actually would go across the board for tremor, that when we engage the autonomic nervous system and help regulate it, because we know that excitability, this is a hyperkinetic disorder, tremor and myoclonus. If the excitability is very high, and if you have a very sensitive nervous system, because you're post-concussion, or you've had migraines, or you're sleep deprived, and so that excitability might be a little bit high, those things that tone the autonomic nervous system will help tremor. And there is literature, even in genetic tremor and an essential tremor, that that autonomic toning can help it. Maybe not make it go totally away in essential tremor, but can help. So autonomic toning things may be very specific to the person, right? So they can be mindfulness activities, they can be breathing activities. It's very specific to the person. It might be heart rate training for people. Another question that came up here from Nicole, is it common to have essential tremor in the leg? I don't know how common it is, but I can look it up. It's not as common, for sure. I actually have not seen essential tremor in the leg. Primarily, it's in the upper extremity. I do have a book on it now because I was getting a lot of books from the library to dive into this topic. So I'll definitely get back to you on more with that, Nicole. But there are other tremors that are more common in the legs. Orthostatic tremor is one of them. So if it tends to come when you're in standing, physiologic tremor in the legs, functional tremor in the legs. Again, shout out to movement disorder specialists, right? Because they look at the whole host of tremors. As I was reading through, I was like, I've never even heard of that disorder before. There's a lot of different rare disorders that fall into the neurology world that may have tremor as part of their syndrome. Tremor is often not by itself. So that's something that's really important to look at and see a movement disorder specialist. I highly recommend it. We work with some great ones here in LA. And it's 1 o'clock already. So I got to sign off. Thank you for the great questions. Jennifer, we're going to have to come back and talk much more about treatment because there's so much that we can do for tremor and myoclonus now. And we're going to have to come back to that. So thanks for asking great questions. Thanks for being here today. And I will catch you next week. Have a great Friday. Have a great weekend.